Active immunotherapies can be applied in 3 different ways. As maintenance therapy after the brain has been cleared from toxic aggregates, as a standalone treatment if in fact they can reduce toxic proteins significantly, or in fact as a prevention strategy to hold the aggregation of the proteins before they actually appear. With an estimated 300 million people living with preclinical Alzheimer, this is not an option, it's actually necessity. Welcome Dr. Philip Scheltens, Professor of Cognitive Neurology at the Alzheimer Center, which he founded back in 2000 at the University Medical Center in Amsterdam, and where he was director until 2021. Today, he joined the investment world, EQT Life Sciences, and heads the Dementia Fund. Together with Philip, we will dive into the advances that are making precision prevention a reality. Dr. Lennert Steukers, sitting here as well, from Johnson & Johnson Innovative Medicine, will then present one of the most exciting and innovative clinical trials, the first prevention trial of an active immunotherapy in a preclinical Alzheimer population. This trial will evaluate JNJ-2056, our phospho-tau vaccine, partnered with Janssen, he will actually demonstrate how the recruitment in cognitively unimpaired patients is developing, but it definitely demonstrates that we are not only talking about precision prevention, but actually it is in clinical development.
I'll talk about disease-modifying therapies in Alzheimer's disease. Not a very unfamiliar topic, I think, for you in the audience, targeting Abeta and tau, the importance of early intervention, ultimately prevention, and enabling AD prevention. What does it need? Early diagnosis, large-scale identification of at-risk individuals based on biomarker profiles or genetics, or both, and of course safe and effective disease-modifying immunotherapies to prevent before the symptoms appear. And that's all sort of under the umbrella of preserving our brain health before disease kicks in. Can we identify these patients early on? Well, yes, we can. And you've heard a lot about p-tau in plasma. This is all sort of ongoing research. We started with CSF, tau levels, p-tau levels, ultimately created the plasma sort of assays, and the very best at the moment, we'll never know what happens in the coming years, is plasma p-tau. And you can see here in 3 different cohorts, the RAP cohort, triad, and the SPIN cohort, against the gold standard of amyloid PET and tau PET, the plasma p-tau actually performs the very best. And here again, it's showing the course of the p-tau levels over time. So it's not only a diagnostic marker, it's also a marker for progression to follow the trajectory of the disease using this. And you can see in blue where A plus, T plus, again on tau PET, that's actually on amyloid and tau PET. You see that there is an increase in the plasma levels over a time period of 3 years. So it's possible to follow the disease also with plasma p-tau, which is really very attractive as opposed to doing repeated lumbar punctures. The real value in a diagnostic test, remember this, is the positive predictive value and the negative predictive value, because it tells you if a patient comes into your sort of consultancy room and he's 82, he has an a priori of having Alzheimer's disease already of more than 80%. So what does then a p-tau test add? Well, in the positive sense, probably not that much. If you can see here on the level, still a few percent, but in the negative ones, a lot. So if such an individual at 80 years with MCI, so in the bottom right graph, if he comes into your office and he has a negative p-tau test, it actually lowers the probability that the patient has Alzheimer's disease. And especially if you go earlier on in a 50 or 60-year-old, the negative predictive value is actually better than the positive predictive value. That means that p-tau can be used to screen out patients with Alzheimer's disease, or actually without Alzheimer's disease, which is extremely important for trials and trial design, and not having to do a PET or a CSF lumbar puncture because the p-tau is negative. So, but the real value is, of course, to predict who will ultimately be amyloid positive on a PET scan, and that has also been shown to be possible with p-tau 217. This is a collection of samples that we had with the Twin Registry in the Netherlands, and we had blood collected 10 years ago, and we made PET scans on all these individuals, and we could look back in which individuals the p-tau actually predicted that the PET scan at baseline would be positive. And you see a very, very high, where the arrow is, a very high sensitivity, again, for predicting those who would later on become amyloid positive. So that opens the window to the next phase, that is the preclinical space. So those individuals that will have no symptoms, will have no amyloid yet, but will have amyloid in the future, or will have already amyloid in the brain, but no symptoms. They may actually be active in society, they may be standing on a podium giving a lecture here, but they may have preclinical AD. And if you look at the numbers, and this is a collective endeavor from the Project Alzheimer's Value, where they collected an enormous amount of data sets around the world, and they calculated how many millions of patients we would have had more if we look only at the preclinical AD patients. So amyloid positive patients without clinical symptoms. And that's all in the gray bars, as you can see here, and that's a terrible amount of millions of patients addressable, and that here comes the clue, addressable for primary prevention, or maybe you should call it secondary prevention, because they already have amyloid. Anyway, prevention of dementia, I would say. And that's an enormous amount of patients that would be eligible for that. As soon as you implement p-tau, for instance, on a population basis, you would be able to detect and find these patients and be in time to prevent dementia, prevent cognitive decline, prevent symptoms, actually. We know that active immunotherapy vaccination actually does help. It does help against polio, it helped against COVID, and it can also potentially actually work against Alzheimer's. Why? It has long-lasting specific immunity for a particular target, as we know. It's consistent, it's boostable, it's durable. We all know this. We have done it ourselves. You only have to do it once or twice a year, or maybe once in a lifetime. There are no observed side effects to date, as we know. It's extremely cost-effective, and of course it's much easier, as was alluded to earlier, than any immunotherapy that is passive at the moment. So, are we doing this? There is a lot of activity in the immunotherapy space, active immunotherapy in Alzheimer's disease. I think really, for the reasons I mentioned earlier, this is really the way to go.
First, some words about the target itself and the mechanism of action. You will see some similarities with the alpha-synuclein talk already in PD. But so why target phospho-tau, and also why engage early in the tau propagation process? I think we all know p-tau closely associated, or the pathology, with neurodegeneration and cognitive decline. What we also know is that the tau pathology really follows that stereotypical pattern, right? And we often refer to a prion disease. It's essentially really that pathological protein that continues to be taken up by healthy cells, and where the cascade, the pathology, is being induced again. Now, what we know about that spreading process, and this has been described by Maisel, as you can see on the slide as well, is that we have two prominent features of the spreading, right? One of them is the spreading from one brain region to another. The other one is more the local replication, the cell-to-cell transfer, and so the growth or the multiplication of the pathology. Now, what we know is that specifically so the spreading event happens really early in the disease, right? If you think about the Bragg staging, and so this is hypothesized to really be a key factor in the disease progression. And so that really opens up, opportunities or possibilities to target these extracellular pathological seeds with antibodies, right? And, as we have heard already, immunotherapy really aims to have adequate presence of these phospho-tau-specific antibodies that really prevent that prion-like spreading, slow really the pathology, the neurodegeneration, and preserve cognition in AD. Again, already highlighted as well, but I can't emphasize enough. I think also bepranemab already demonstrated now that they were able, with their monoclonal antibody, to slow tau pathology as measured by tau PET. And this is really the first tau-directed antibody to do so and supports the hypothesis that we are able to intervene with that pathological spread. Tau active immunotherapy, JNJ-2056, as currently being developed specifically for the treatment of preclinical AD. So first some words about the liposomal drug product, which is really designed for high specificity for a phospho-tau response and a robust, durable immune response. As you can see on the slide, we took a short linear peptide sequence at the end, so at the C-term end of the phospho-tau peptide, to anchor that really in the B lipid, the small cell, if you like, liposome. As you can see, what we additionally anchored to that as well are two adjuvants to really help with the immune response as well, and very deliberately also a T-cell peptide, a universal T-cell peptide, to really help the immune response to focus on the B-cell-induced humoral antibody response. As you can see, I mean, the C-term end really has been chosen as well. I think it has been mentioned that the N-terminal directed therapies have failed. We do think that, being in either the core or the adjacent regions is the better target because they are also more conserved across all of the p-tau species. So why target tau in preclinical AD, right? Because we really think this is the optimal window for disease modification, really prior to the substantial neuronal loss, but close to symptom onset. And again, think about what I mentioned, the mechanism of action. The spreading event also is a very early event, so we need to go early, right? But so I think the challenge is, and this is where also our precision approach really comes into place, we are targeting preclinical AD defined as being amyloid and tau positive, right? And so it's a matter of trying to go early, but we also want to make sure that we are able to see within a trial sufficient progression in individuals if we want to measure a treatment effect in a reasonable amount of time, right? And so that is the approach really for this study. But as you can see here, these individuals, which we believe really will benefit most from treatment, are really at the verge of symptom progression, right? And progressing to that next stage. As you can see here, the data from Ossenkoppelen, I think also recently confirmed by the A4 data as well, that people that have A and T pathology in the medial temporal lobe, but also in the neocortex, they do progress to clinical symptoms within 4 years, right? So 50% of these, as according to the survival analysis, will progress to the MCI stage. So retain a secondary prevention study, not primary prevention, so these people have the pathology but no symptoms yet. And so we're doing currently a multi-center randomized placebo-controlled double-blind parallel group study to look at efficacy, safety, and immunogenicity of our J&J compound in preclinical AD. And the study really is ambitious, right? Bold. I mean, we really want to test the hypothesis, so proof of concept for J&J that it's able to slow the spread of phospho-tau, but also slows cognitive decline over 48 months of treatment compared to placebo in roughly 500 people with preclinical AD. In terms of the endpoints, the primary endpoint, we are using PAC5 as a very sensitive measure to detect change over time in this early stage population. A key secondary clearly is, effects as measured on tau PET on the tau pathology. So again, change from baseline. Other secondary endpoints do include the CDR global score, which is used for a time to event analysis, the CDR sum of boxes, the MBIC, so the NPI if you like, but then for preclinical stages, the ADCS, ADLPI, quality of life AD, volumetric MRI, and CSF plasma biomarkers as well. An exploratory endpoint that we are including is a multimodal digital biomarker that we are also assessing for longitudinal change in this population, right? With the hope that we're also able to detect on such measure, change earlier to help with the decision making. The study design, think quite straightforward. So we do have a 4-week pre-screening phase where we are really trying to identify people, should be seen as an enrichment step that will likely be positive on the tau PET scan, right? And so we are using in this pre-screening step a blood test, the Quanterix Lucent AD blood test, to help with that enrichment for the tau PET positivity, right? So really bringing that probability of someone testing positive on tau PET up. We're also doing a speech test during the pre-screening period. Again, it's not being used for decision-making in Retain or to guide any patient decisions in the funnel, but again, it may be a useful tool to help with, other trials to help with the patient identification. This pre-screening period, if people are eligible, then they will move to screening. The disclosure clearly will happen for, all positive people as a very first step. And then the more general in and exclusion criteria will be checked only if they satisfy all the criteria, they will move to the MRI and to the PET scan. 1-to-1 randomization for those considered eligible, and people will be treated for 4 years. It's an active immunotherapy. The first 6 months we use 3 immunizations to really help with the induction of the immune response, and then we follow for the entire 4 years with 6 monthly booster immunizations to really support that durable immune response. Key inclusion criteria, 55 to 75 years of age. They need to have elevated brain tau pathology as measured already on a screening tau PET scan. So having some evidence, if you like, of the pathology on tau PET. They need to be cognitively normal, and we use the CDR of 0 combined with at least a 27 on the MMSE with educational adjustment to be considered cognitively normal. Key exclusion criteria that I want to highlight here is clearly, if there is any diagnosis of non-AD or too advanced AD already, like through dementia stages, for example, they will need to be excluded. Also, people with a diagnosis of MCI will be excluded. If people have been on an anti-amyloid therapy, we're also excluding them from the Retain study. And then clearly the next two are linked to, of course, we're working with the immune system of participants. Any abnormal function of the immune system or, pre-existing anti-nuclear antibodies, which could be indicative of an underlying autoimmune disorder, they will be excluded for the purpose of this trial. But so how do we now measure spread, right, on tau PET, especially because, again, thinking about the mechanism of action, we're trying to limit spread. We're not trying to, in a way, reduce aggregation at places where aggregation is already present. And so the endpoint we have created for our anti-tau trials that are targeting tau seeds is really an endpoint that is maybe like an individual endpoint or could be considered an individual endpoint, but we're essentially looking at in how far has a person developed, pathology in regions that were naive still at baseline, right? So we do a baseline scan, as you can see on the scans. On the scans presented, we look at it's voxel-based, all the entire, voxels across the brain. If these voxels that are not within one standard deviation of normal, so of the controls, so the ones that are within, that range, they will be considered naive, right? And so that will be the naive region of an individual, and we will measure, in how far spread has happened over the course of the trial. Study status. So we initiated pre-screening last year in April 2024, and we're currently enrolling already at 69 sites in 7 countries. Key takeaways. So my final slide as well. Our precision neuroscience approach that we have demonstrated here is really, in that sense, the first anti-tau treatment being tested in sporadic preclinical AD in the RETAIN study. We are really committed to demonstrate impact on disease progression and or clinical improvement using precision approaches, right? And we're using a precision approach in the patient selection by using our innovative JNJ blood test followed by a tau PET scan, in essence trying really to identify those people that are likely to progress and will also benefit most to that point. We're also using precision measures that really are designed to demonstrate treatment-related slowing in the spread of tangles using these novel tau PET endpoints. The use also of really cognitive measures that are very sensitive to detect changes in this early stage, such as PAC5, and then also that exploration of a potential digital endpoint that could help with detecting this change over time. It has been already a great endeavor so far. Also, our J&J teams globally to support this trial are doing really an amazing work, and I also want to thank our collaborator, AC Immune, for their continued support. So, thank you.